Welcome to NorthBay Healthcare's Doc Talk Live. Please welcome Dr. Andrew Brooks.
Hello. As she said, my name is Dr. Brooks. I'm an orthopedic surgeon at NorthBay, and I specialize in hip and knee problems, specifically arthritis of the hip and knee. And I've been doing knee and hip replacements for about 25 years. And so what I'd like to do is share with you some insight into what arthritis actually is, treatment options, both surgical and non-surgical. I'm also medical director of the Joint Replacement Program at NorthBay Vaca Valley Hospital, which has been present for about 13 years. So what is arthritis? That is a common question, and not everybody fully understands. And what I'd like to do is kind of explain what that actually means to you. In your joints, your hip, your knee, your shoulder, your hands, they're covered with a very soft, smooth substance called cartilage. When that cartilage is damaged for any number of reasons, we call that arthritis. And when you have arthritis, you notice it because the joint becomes painful, stiff, swollen, and inflamed, and occasionally can become very deformed. So this is an image of a knee, and you see this smooth, glistening, shiny cartilage covering the end of the bone. You can also see the ligaments and the meniscus, which are components of your knee cartilage. This is an x-ray of a normal knee, and you can see the nice space between the two bones, and that space is filled with the cartilage. The opposite x-ray shows a knee that has severe arthritis. You see loss of that space between the bones, almost completely fused. This is bone-on-bone arthritis. This is severe. This is a side view of the same knee. On my left, you'll see a knee that has normal appearance, and on the right, you'll see a knee that is severely deformed from arthritis, and you see large bony spurs and bone-on-bone arthritis and deformity. This is a look inside of a normal knee, and this is a pointer or a probe, and we're probing the meniscus, but you can see the nice, shiny, smooth cartilage covering the bones. The opposite picture is a knee that has moderate arthritis. You can see irregularity, some deformity of the cartilage, almost like a road that has potholes in it. It is no longer smooth and shiny. And this is a patient who has moderate arthritis. When the arthritis is severe, most of this remaining cartilage is gone, and we have simply exposed bone. This image here on my right is a surgical image of a patient who is undergoing a knee replacement, and you can see just how deformed their knee has become from the arthritis. This is the kneecap, but you see the wear on this bone as well, and this patient had quite a significant deformity. As you lose the cartilage, eventually you start wearing down the bone. This is a picture of a normal hip on the left, and you see a nice round femoral head and a clear distinction between the femoral head and the socket. And on this side is an arthritic hip. You see the femoral head is starting to move out of the joint. You see complete bone-on-bone and deformity, and these dark areas are large cysts, which are fluid-filled cysts, which is a sign of severe arthritis. Up top, we see an x-ray of a pelvis with normal hips, and down below, we see an x-ray of a patient with severely arthritic hips, completely bone-on-bone on each side. And then to the right of that is a patient, this same patient, after having undergone hip replacement on both sides. You see the new socket, the new stem, and the femoral head. So there are many types of arthritis, as I mentioned previously. The most common is osteoarthritis, which most people call wear and tear arthritis. But you can have autoimmune arthritis, which is lupus or rheumatoid arthritis. Gout can cause arthritis, and if you have an infection in a joint, a Lyme disease or a bacterial infection, or in the past we used to see it with tuberculosis, you can have a septic arthritis, which destroys the cartilage. The end result of all these types of arthritis is the loss of normal cartilage. The cause, we say for most patients, is multifactorial. Genetic is a big component. If you had mother or father who had arthritis, you're going to be at higher risk of developing arthritis yourself. We see arthritis frequently as a result of an injury where there had been some damage to the knee or hip, or in some patients who were born with a crooked leg, we call that malalignment, and that changes the way the forces go across the joint, resulting in increased wear and tear. Patients who had multiple prior surgeries on their knee, higher risk of arthritis. Those patients typically have lost cartilage or meniscus, predisposing them to developing arthritis. Obesity is frequently associated with arthritis, and that is a significant problem because 1/3 of Americans are obese. You simply can't load the hip and the knee with all that extra weight and expect it increases the forces across the joint and lead to increased wear and tear. So when we talk about treatment options for arthritis, the first thing we think about is staying physically fit, exercising, possibly going to physical therapy. There are many studies that support the use of physical therapy for knee arthritis. Maintaining your strength, your range of motion, your balance allows you to maintain your independence and freedom in activities. Other conservative measures include weight loss, as we mentioned earlier. Even losing 10 to 15 pounds can make a big difference on the forces going across your knee. Every pound overweight someone increases the force across that knee 3 to 7-fold. So it makes a big impact to lose 10 to 15 pounds. A cane can reduce the forces across your knee by 50%. So we recommend that sometimes, especially in people who like to go on long walks. They use walking sticks or canes. That helps unload the pressure from the knee. Activity modifications are simply choosing activities that don't aggravate the knee. You cannot do a lot of high impact type of activity and expect to get by if you have a severely arthritic knee. It will simply make it worse and more painful. So we choose low impact options such as bike riding or swimming and doing some walking. There are certain braces designed for people with arthritis of the knee, and some people are candidates for a special brace that can take the pressure off of their knee. Medications, probably the safest one is Tylenol arthritis, as long as you don't have any history of liver problems. Tylenol does not affect your kidneys, so it's generally safe in patients with kidney problems. But there is a limit on the amount of Tylenol you can take, and you need to talk to your doctor about that. Tylenol arthritis is specifically made for patients with arthritis. It is a slow-release Tylenol that can be helpful. Anti-inflammatories, we call them NSAIDs, but anti-inflammatory drugs such as Motrin, Aleve, Advil, they can be very helpful as well, and frequently we use them in combination with the Tylenol. Those medications can affect your stomach and your kidney, so you got to make sure that it's safe for you to take those, and you might want to talk to your doctor about that. Many of my patients take supplements, and that is a big market, and you'll see them everywhere. And the problem is we don't have any proof that they actually are doing any good. So you have to ask yourself, if you're taking supplements, are you feeling better? Does it seem to alleviate any of your symptoms? Occasionally I have a patient who does feel as though the supplement is helping them. And because most of those supplements are pretty safe, I support their choice to take those. But I wouldn't just take them randomly because you hope it's going to help. I'd take them for a while and ask yourself if it's helping. If it is, then continue taking. There are many topical creams and lotions that people use for symptom relief, such as Bengay or Icy Hot. And there are patches as well that people can put on their knee, a lidocaine patch, which numbs up the knee a little bit. They have Voltaren patch, and they also have Voltaren cream now over the counter. That is an anti-inflammatory that you can rub directly into your hands or your knees for arthritis, and it's pretty safe. Steroid injections are commonly done for arthritis because they can be extremely helpful, especially if somebody's having a flare-up. But we don't recommend using them over and over again for long-term management because there are some detrimental effects of the steroid over a period of time. There's another injection called viscosupplementation. You might have heard of it, also called hyaluronic acid, which you normally have in your joints anyway, and this is just supplementing what you have. It is given just like a steroid injection is given, and it would help probably 50 to 60% of my patients with knee arthritis. Very few risks with that, and we do use that frequently. People often ask me if they can just have a cartilage transplant for their arthritis, and the short answer to that is no. Cartilage transplantation is not a treatment for arthritis. It will fail. It is a treatment for isolated cartilage injury in a healthy knee. This is just an image of a cartilage transplant, but you can see the articular cartilage around the knee is smooth, normal. There's an isolated injury here, and this is a close-up after having transplanted cartilage to that area. The remainder of the knee is normal. The patient has normal alignment, normal ligaments, and so they're considered a candidate for cartilage transplant. There are other techniques as well, cartilage transfers from one part of the knee to the other. In the past, we used a treatment called microfracture, and that's still being done in certain isolated instances, but again, that is for isolated lesions in an otherwise fairly healthy knee. Stem cell injections receive a lot of press and a lot of interest, and at some point in the future, they will be considered a treatment for arthritis, but currently there is no indication for stem cell therapy for arthritis simply because we don't have any reliable data that proves it is helpful. There are many stem cell clinics that have popped up all over, and there are many of them in Florida, and they advertise for all kinds of therapies, but the FDA, the Food and Drug Administration, is closing many of those clinics down for making false claims. So I don't recommend my patients spending $20,000 to receive stem cell injections in their arthritic knee simply because I don't have any evidence that it's working. As I mentioned, someday in the future, that probably will be an option. They're working on that right now. So you've had your conservative measures, you've lost your weight, you've taken your medications, you've modified your activities, maybe you've worn braces, had injections, but you're still pretty miserable and you cannot do the things that you want to do. Now you're thinking about an operation. So when should you consider surgery? When your everyday tasks, such as going out and getting the paper, going to the store, getting out of bed, become painful and bothersome. When you can't sleep at night because of pain. When you have chronic inflammation and swelling and stiffness that seems to be getting worse and worse, or you're starting to notice some deformities such as a knock knee or a bow leg deformity that you did not used to have. When your quality of life becomes compromised, you need to start considering an operation. And the operations for arthritis can be broken down into arthroscopy, total knee or total hip replacement, or partial knee replacement. Arthroscopy is now seldom done simply for arthritis unless there is evidence that there may be a loose piece or a large flap of something that's loose in the knee or causing the knee to lock up. Simply cleaning up a knee with arthroscopy has been shown to not only not be that helpful, but possibly to worsen the situation. Total knee replacement, as you probably are aware, replaces all the surfaces in the knee, and partial knee replacement replaces only the damaged part of the knee. There are no age limits really for joint replacement. In the past, I would say the majority of them were done in patients between the ages of 60 and 80, but because our techniques are better, because we have managed to make it a safer operation, we will extend those limits in healthy patients. So yes, we've operated on patients in their 90s with severe arthritis. And if you have somebody in their 90s who's completely functional, but they can't move because they have knee arthritis and their health is excellent, then you would consider doing that. We are doing them in younger patients as well, but of course we try not to, because a joint replacement doesn't last 60 years. It typically lasts about 20 years. So in a young person who has a knee or hip replacement, they'll have to have another operation as they age. This is a photograph of a patient who is just about to have a knee replacement. And you can see just how crooked that knee is. That patient somehow was able to wait many years before they decided to proceed. Unfortunately, that's done some damage to the knee, as you can see. So our job is to get that leg straight and replace that knee. And that can be challenging in deformities like this. This is the x-ray of the knee. You can see just how deformed that knee is. This is after the surgery. And now we've straightened the knee. We've removed all that deformity, and now there is total knee replacement in place. She actually had two knees that were exactly the same, and this is how she is after surgery. So she's probably a foot taller as well. So there is a difference between a whole knee replacement and a partial knee replacement. The whole knee replacement replaces, as it says, the entire knee. All surfaces of the knee get replaced with metal and plastic. And the metal is titanium and chrome cobalt, and there is a special liner in between called a polyethylene liner. So that's a whole knee replacement. This is a partial knee replacement. It just replaced the arthritic side of the knee because the other side of the knee was completely normal, and this patient did not have any significant deformity, and so they were a candidate for a partial knee replacement. Not everybody's a candidate for partial knee replacement with knee arthritis. Possibly 1 out of 5 patients are. So whether or not you are a candidate needs to be discussed with your orthopedic surgeon. There are some great benefits to a partial or unicompartmental one-compartment knee replacement, but there are some requirements as well, as I've listed here. The partial knee replacement is a very popular operation because it's a smaller operation, less bone is removed, the recovery is easier, you have better range of motion, your knee feels more normal afterward. So something that I stress to my patients is the recovery from a knee replacement can be very demanding. They need to understand that going into the operation. If you understand that it's going to be painful, require a lot of physical therapy, and take anywhere from 3 to 9 months for your recovery, if you know that going in, you tolerate it much better and you're mentally prepared to deal with those challenges. The hospitalization in the past used to be 5 or 6 days. Now it is 1 day for the vast majority of patients, and some patients can have it done outpatient. There is physical therapy required. Generally, that's 2 to 3 times a week for about 6 weeks. You have limitations on driving. If it's your right knee, it's 6 weeks. If it's your left knee, it's probably 4 weeks. Many people require pain medication or narcotics in the first couple of weeks after surgery. Those medications can have side effects. such as constipation, drowsiness, sleepiness. So you need to make sure you're monitoring all of that. Most people are off work anywhere from 6 weeks to 12 weeks, depending on what their job is. And when someone says, when can I consider to be back to normal? I tell them that it depends a lot on the patient. So some people at 6 weeks feel like they can do about whatever they want. But I have patients who don't fully feel recovered for about 9 to 12 months. And that's, like I said, that's very independent depending on the patient and their expectations. Hip replacement definitely is an easier recovery. The pain from a hip replacement can be excruciating the pain from hip arthritis can be excruciating. And after surgery, the pain is minimal for most people. There is a few weeks that you have to recover, but most people are very active within about 6 weeks after a hip replacement. There are different ways to do your hip replacement, and we can discuss these at an office visit, or you can discuss them with your physician as to whether or not that surgical approach makes a difference for you. As I mentioned earlier, we expect about 90% of joint replacements to last 20 years. Some of that depends on how well you take care of them, the quality of your bone, your health, how well they were placed at the time of surgery. The number of joint replacements are increasing simply because, as I mentioned, doctors are getting better at it. The technology is better. The surgical preparation, the intraoperative care and postoperative care is all improved significantly. And so in 1990 in the United States, there were about 130,000 knees being replaced and about 100,000 hips. In 2010, the number of knees went up to about 500,000, and the number of hips is well over 200,000. And around 2030, they're expecting that number may jump to 3 million. At any point in time, there's at least 7 million Americans walking around with a hip or knee replacement. So the operation is associated with risks, and we spend some time in my office reviewing these risks so that everybody can make an educated decision as to whether or not they want to proceed. Some patients have higher risks than others. These are risk factors for surgical complications: obesity, smoking, diabetes, poor nutrition, patients with rheumatoid arthritis, lung problems such as COPD, kidney failure, alcoholism, prior infections. So we go through your history extensively prior to deciding upon an operation and make sure that you don't have any risk factors that can be modified or improved prior to your surgery. We spend a lot of time talking to patients about obesity because obesity is clearly associated with a higher risk of infection. So we want to make sure that patients are aware of that and address that prior to undergoing surgery. Having an infection in your joint replacement is a disaster. So we need to make sure we've done everything we can ahead of time to minimize that risk. We will not operate on anybody smoking because the risk is too high. Patients with diabetes need to have their blood sugars in good control, and we can help you decide what that is. Nutrition is critically important, and we look at your nutrition laboratory studies to make sure you're safe to proceed. Patients with rheumatoid arthritis need to make sure their rheumatoid arthritis is in good control. Those patients take medications which could place them at higher risk for infections, so we talk to them about holding off on those medications for a period of time. So some of the risk factors we can diminish. Some risk factors we can't, but we do address what we can prior to surgery. At NorthBay, we have a joint replacement program, and a joint replacement program is comprised of a group of professionals who have a very well thought out evidence-based protocol for not only the surgery, but prior to the surgery and after the surgery. All decisions and treatments are based on evidence for your maximum benefit. And as I mentioned, our joint replacement program began in 2007 with a goal of optimizing the outcome, accelerating your recovery, and decreasing your complications. So when you come into the hospital, you're being cared for by people who know exactly what to do and how to take care of you, and you're treated a little bit separately from the other hospital patients who are in the hospital because of an illness. There is a pre-operative program, including an education component, a pre-surgery class. There is a computer-assisted program that you are hooked up to online that guides you through the entire episode of surgery. We teach you about pain control techniques and how to recover safely at home afterward. And our joint replacement program has won numerous awards and accolades, and we're very proud of those accomplishments. So there are many companies that sell joint replacement. There are many companies that research joint replacements, and we're always looking for the next best thing in joint replacement. But it does take a while to prove that new technology is going to be beneficial. So we've been doing knee replacement since 1968, and there's been significant changes since then. The materials are probably the #1 improvement since that time. Our materials now last longer than they used to, and that has been really good for patients who used to have their knee replacement redone after 7 years. Now we can expect up to 20 or more years. We use robots, have custom knees, computers, and surgical approaches and implant options have all improved. We've done computer-assisted surgery in the past, and now many facilities have robot-assisted surgery as well. There are customized knee replacements for patients with extremely deformed knees and patient-specific instrumentation designed for those patients. I think I'll skip that. So if you have any questions or concerns or would like more information on this, you can go to northbay.org. And another excellent source of information is orthoinfo.aaos.org. That is the American Academy of Orthopedic Surgeons information site that will give you transparent, helpful information about hip and knee replacement. So I appreciate you listening to me, and I hope this was helpful for you. Thank you.